Good afternoon, everyone, and welcome to our webinar about Avant-garde Health CMS TEAM Bundled Payment Analytics Product and Strategies for Success. So one of the most interesting parts of participating in CMS value-based care programs is access to claims data, where you can see claims level detail about how much your Medicare patients cost, and most importantly, the variation in cost by surgeon and by facility. So we're going to share how we support hospitals with data analytics and insights. But first, we're going to do a few introductions. My name is Ann Conrath, Director of Sales at Avant-garde Health. I have worked in value-based care both on the clinical side and on the tech side for the past 12 years, including working for a convener in the BPCI program and facilitated orthopedic and cardiac bundled payments across the country. I have seen firsthand that in order to move the needle on cost and quality metrics, you have to have accurate, detailed case cost data to support physician and clinical team behavior change, which is what bundled payments is all about. So I'm really excited about our discussion this afternoon. I'll toss to Porter to say hello.
Thank you, Ann. My name is Porter Jones. Wonderful to be here with you this afternoon. I've spent over a decade both in hospitals and on this side of the table focusing on value-based care, which has included bundled payments. So really excited to have this discussion and share some of our best practices and case studies with you this afternoon.
So to share a bit of context with folks about why we are in the bundled payment business. So here at Avant-garde Health, we partner with health systems across the country, and they have a few core challenges when it comes to understanding their surgical cost data. So health systems have struggled to identify where do we cut costs, or how do we standardize their supplies by procedure at scale, because the data that they have is oftentimes decentralized, incomplete, it's not accessible, and these reports are typically created manually, which can be prone to errors. And so then making any kind of decision to reduce cost is incredibly difficult and slow. So as a result, there is massive financial waste in the OR every single day. And for that reason, we have created advanced surgical case cost analytics and AI to drive cost reduction efforts across service lines. Because our core mission as a company is to decrease unnecessary costs and improve the value of surgical care, we started doing Medicare bundles since CMS's first program in BPCI, and we have some really exciting outcomes to share with folks.
So at Avant-garde, we've spent numerous years working within the BPCI program. And I understand that team is slightly different, but it is somewhat similar. And we have learned a lot through that process, working through with these institutions through the BPCI initiative. One case study we wanted to highlight, which was actually published in the Harvard Business Review, was a case study of our work that we did with Hollywood Presbyterian Medical Center. Now, working with them, we were on average able to be 15% less on a case-by-case basis compared to the target price. In addition to that, we saw a 7% decrease in 90-day post-discharge mortality rate and a 5% reduction in 90-day readmissions. A few learnings that we saw was the importance of creating a team that was aligned and had a clear direction of what needed to be done and how it needed to be done. Another learning from that, which you can also read in the Harvard Business Review, was the importance of a digital platform or a product that allowed you to track and really understand and analyze case-by-case details, both on a hospital basis, but all the way down to an individual case basis by per physician. So as we go through this, we will also show how we are going to take our best practices from BPCI, roll that into what team is going to be in 2026, and make some of those adjustments to help you as well be just as successful as Hollywood Presbyterian was.
So we also wanted to share a few high-level logistics about TEAM. So it starts on January 1st, 2026. It's going to run for 5 years. It's a 30-day bundle that starts on the day of discharge. The 5 clinical episodes that are going to be included in the program are listed there. And this program is for your patients with Medicare as their primary payer. So no Medicare Advantage or any managed care plan. It's going to include all of your Medicare Part A and Part B services. There are some exclusionary criteria, like patients that are admitted for organ transplants, oncology treatments, or any trauma-related medical admission. Those services are not going to be included in your patient's bundle. The other thing that I want to highlight here about the target price. So the target price is going to be at the DRG level. It's going to be set regionally based on census division. So each participating hospital is located in one of 9 census divisions. So the baseline data within that census division is going to inform your target price. Participating hospitals can expect to receive their baseline data sometime this fall. That's what we've seen in previous programs. And the good news is that everyone that has an opportunity to have no downside risk in year 1, if they choose. All things considered, unless you're a safety net or rural hospital. And certainly for hospitals where this is your first time doing bundles, we definitely recommend choosing track 1 so that you can have some extra runway figuring out your bundled payment program. Another thing that I'll share and add here is that the hybrid hospital-wide all-cause readmission quality metric is now optional in year 1, but it is going to be mandatory in year 2. And CMS is going to let us know about those target prices each year before the start of the performance year. Since CMS has implemented bundled payments, we have over a decade of experience, and we offer a host of services outlined here to make sure that hospitals are going to be successful in those programs. So we're going to zoom in on data analytics, because in this value-based care market, you have to understand both your direct costs of doing surgical care and your Medicare spend and utilization when it comes to your TEAM clinical episodes. So we're really excited to demo how we do bundled payment analytics to support hospitals. So I'm going to stop here for a moment and pivot over to Porter, who's going to share a bit of information here about our analytic platform.
Great, thank you, Anne. I think as Anne had mentioned, we do understand that many of you are embarking on this journey for the first time, being part of TEAM in 2026. And we want to provide you or show you what a tool can do for you as you are preparing for this and as you are going through that journey at the beginning of next year. As we'd mentioned, what we learned with Hollywood was the importance of having detailed data and access to the analytics at any time to be able to make adjustments, understand where you were at, understand where you need to be successful in this program. Taking a first look, this is a high-level overview of a hospital view. So you're going to see all the bundled payments here, everything from CABG to your major bowel procedures. We want to give you a view of what is going on with your facility for the TEAM program. You will see initially in this column, you're going to quickly see what is your risk-adjusted target price. So this is unique to you, so you understand where you are targeting and where you should be. We're also going to show as cases become live and we're able to get access to the results or to the outcomes of what you were able to achieve, we're going to now see what your delta was from the target. So understand, were you below cost, were you slightly above cost, and how far away from that from that risk-adjusted target price are you? And as we continue to move over, that's where we're going to be able to provide you a total predicted reconciliation, or give you an idea based on the number of cases multiplied by your delta or your average delta from the target price, what does that reconciliation look like? And then finally looking at where are you either ahead or behind of your target price. So in this instance, it's 27% ahead. Now, as we're able to look at all of the bundles throughout this, we're able to give you a predicted reconciliation for this particular year. And that would be based on what has been achieved and where you're going with the current bundles that you're participating in. Give you an overall idea of how far or where are you at compared to the target price. So in this instance, it's 10% ahead of the target price. And then depending on the track, this will be unique to you, but this also gives you an idea of what is your potential earnings if you were able to achieve that 20% cap. For example, if you were in a track where you had that 20% upside or downside for that particular track. So we want to just be very clear, where are you at, what is your potential, and then the details behind every bundle that you were in. Now, we also know that we need to get even more detailed into this. And so now we're able to look at the bundle details. So as we mentioned, we still will have the risk-adjusted price. Where are you at from the target? What is your predicted reconciliation? Now we're going to be able to give you the exact number for your total episode spend. And then we want you to know these two important numbers. What is your index admission? So really DRG based. And what does that non-index portion look like when looking at the overall episode spend? So what is that post-discharge spend looking like? So we know that is where we're going to be spending a lot of time understanding how to manage the post-discharge and keep those costs down as optimally as possible. And two major components of that would be discharge home, so giving you a percentage basis, how many patients are being discharged home, and then also a 30-day readmission. So that gives you a little bit more detail on a bundle level. And then what we find has been extremely important in regards to physician engagement, engaging the correct leadership within the hospital, is also being able to show and provide physician level details. So in this, now we're just looking at one particular bundle. So looking at coronary artery bypass grafts, and we're able to see on a physician by physician level, where do those physicians land in regards to your target price for your institution. So our fictitious Max Planck right here is quite above that target price. And then we have other individuals down here that are quite below the target price. So this gives us an idea of what the clinical staff within your facility is actually doing. We're also able to do, if we want to look at it in more detail, we're able to actually then pull out, so not just a graph comparing to the target price, but really get detailed into what is that particular physician doing and seeing the details of the cost of their cases. So we will dig in just a little bit more because we do have one more view that I think is important, is the physician view. We found that physicians like to look at this just as much as the administrators. They like to understand where they're at, where they stand. Sometimes they even like to really compare themselves to their peers so they know what they can do better or how they can adjust to the rest of the peers within the hospital. So now we have a physician view. We can look at all the physicians, which is easy. Again, this looks very similar to the overall view, but now we can start digging into individual physicians as well and getting an idea of where they stand. So now this is going to be just one physician looking at their cost structure, looking at the number of cases and the bundles that they are participating in. And then we're able to then go down and look at individual cases. So this is within one physician. This is a physician view with one physician and all the individual cases within this bundle and what is going on with those individual patients. So this really gives us that granularity that allows everyone to have that view of what is going on, where do we stand in the program, how do we be successful, and then where do we need to make these adjustments. And this allows us to track how also once those adjustments are decided upon, we can track how those adjustments throughout the year are actually affecting the price and and getting us closer or further away from the target price that has been set for the hospital. So we find this extremely beneficial to be able to start very high level and dig all the way down to an individual patient and procedure view.
And the other thing too, Porter, I'll share here as well, and where this has been really helpful for health systems, especially if systems and hospitals have a gain share in place. So of course, this can be incredibly motivating as you begin to do this type of work, and so that surgeons can see what is my contribution? What is not only what is my performance relative to my peers, but they can see their financial contribution, how much revenue that they're able to generate, in addition, of course, to their regular fee for service. But then this is just kind of an additional source of revenue when they're looking at doing bundle payments. So having that detail when they can look at that by case has been really impactful for our customers that are doing this type of work.
And I think that's a great point. And I will refer back, and we can send this asset. The follow-on to the Hollywood Presbyterian case study written up in the Harvard Business Review was just that. How to engage your physicians in some sort of financial or gain share program. This was written by our CEO, Derek Haas. We will definitely share that because I think it is extremely important, as I mentioned, to have full buy-in from the physicians as we move throughout this program. The only thing I wanted to finalize on as part of our tool, we also have a PAC tool, which allows you to be very prescriptive on your location and where there are options to place your patients post-discharge. Obviously, as much as we can do a discharge to home is optimal, but we want to provide a tool to where you can see facility by facility, what is the average number or length of stay for a particular procedure at that facility. We can even give you a predicted or an expected post-acute care cost at that facility, and then your expected readmission from that facility. So it is very unique to your geography. We want to give you the tools and empower you to be able to make these decisions as you're going throughout this program to be as efficient and choose the facilities that are going to be best for you and, most importantly, best for the patient. And I'll stop there and I'll throw it back to you, and we're also happy to answer any questions at the end.
Yeah, absolutely. And as I'm bringing up kind of a final component that we wanted to share with y'all, and what Porter had outlined there with the PAC information. And so recognizing that a lot of organizations have their preferred network. And so that's exactly what the tool is going to be for, just a resource there. And knowing that your patients, of course, you have your preferred list, but your patients are coming from an incredible radius, oftentimes, certainly for certain hospitals. So just wanted to share that additional use case there. And so because our mission as a company is to support hospitals transition and succeed in value-based care, we are really excited to offer a CMS TEAM collaborative. This collaborative is free to join and participate. So 2025 is our time to prepare. We're going to offer educational webinars about the logistics of TEAM, as well as bundle payment best practices, operational strategy sessions to assess current clinical and financial status, helping you create action plans around the core components of bundle payments. What do I need to be doing to be successful here in this mandatory program? The data and track selection analysis is a really huge piece of this collaborative because you win when you understand your Medicare cost data, and you win even more when you have great analytics and insights about where and how to take action to reduce unnecessary cost. So we'll be able to ingest your Medicare baseline data when we get it this fall and help you choose the right track selection. So we would love for you to join us along with other health systems like Avant-garde Health and Penn State. And we're going to have a kickoff webinar on May 8th. So you can sign up on our website to make sure that you have the latest information there. We'll be sharing this information with folks certainly, or you can email me directly about follow-up information, or just wanting to make sure that you're on the listserv and wanting to participate, whatever would be convenient for you and your institution. So that was the majority of information that we were excited to share with you all this afternoon. Wanted to open it up for Q&A. If folks have a question, please enter it into the chat. This can range from anything, whether certainly about our analytics that we offer for hospitals, or about the TEAM program, any logistics there, information that you're curious about the collaborative. Go ahead and ask those questions in the chat, and we would love to discuss those about what's important to folks. One question that's coming in here, question about the logistics of TEAM. Is there any exclusionary criteria for the TEAM program? Yes, there is. So I had shared with you that there are certain services that are going to be excluded from TEAM episodes. But other components, just to share, there's going to be certain major diagnostic categories that are going to be excluded from that. Like one example is like HIV-related conditions. Those are not going to be included in TEAM. Certain high-cost Part B drugs and biologics are not going to be included in there. So just a couple of other exclusionary criteria there to make sure that, CMS wants this program to work. So they're not going to include things that certainly institutions don't have an overwhelming amount of control over to control the cost there. Great question. Let's see, another question just came in. Are there risk adjustments to account for patient complexity? Yes, there are. So CMS is going to take in a number of different components here when they think about looking at your Medicare spend relative to that regional target price. So they're going to be making some beneficiary level adjustments. They're going to be looking at things like age, making sure they're looking at those HCCs. So that's another huge piece of doing value-based care, is making sure that all your care gaps are closed, documenting those HCCs for all of your patients when they're coming in, certainly before the surgical episode. They're going to be looking at any prior post-acute care history there. And then they're also going to be looking at the social risk of the beneficiary. So they're also taking in things into consideration like the area deprivation index. That's a huge component of all of value-based care programs coming out of CMS, having that health equity component. So those are all pieces there that are going to be included in that risk adjustment for the patients. Excellent. Let's see. One question, did you say that the hybrid hospital-wide all-cause readmissions is now optional? Yes, so that is optional year 1, but it will be mandatory year 2. Okay, great. Well, looks like those are all of the questions that have come in from folks for this afternoon. So we will go ahead and adjourn, but really grateful for everyone's time this afternoon. We're so excited about the program. We're really excited about the collaborative and the shared learning opportunities that we have in doing this work together. So please keep tabs on our website, and also that's my email address there, about ways that y'all can get involved. Again, participating as much or as little as you desire. But either way, really excited to move forward in this value-based care market, and excited to talk with y'all next time. Thank you so much for joining.
Thank you.